सभापति प्रोफेसर कौल साहब, सभागार में उपस्थित मेरे अग्रजों और मेरे मित्रों, I am Dr. Madhur Uniyal, an associate professor of trauma surgery at AIIMS Rishikesh, and today I am going to tell you the trauma healthcare delivery in hills, the AIIMS Rishikesh story. Though this is a story of a small state of Uttarakhand and is limited by the work done in AIIMS only, but the problems which we have identified and the solution which we have realized can be extrapolated to situation of all the hills, hence relevant for HIMSamwaad. When I talk about trauma, first thing we realize is that Uttarakhand and other hilly states, they don't have that much of disease burden. We think trauma is a problem of motorized states, like the 13 motorized states in the country in which these hilly states don't figure out. But when we see it in perspective of dailies, that is disability adjusted life years, which is years of life lost due to disease or death. For example, if a 20 years old child dies in an accident and expected age of survival in India is 70, so the society loses 50 years of young blood. So when we talk in terms of dailies, small hilly state of Uttarakhand tops the world. So it gives us the magnitude of the problem. Dear friends, we developed a level 1 trauma center in AIIMS Rishikesh. The inspiration was the 2013 Kedarnath disaster only, and then I put in a thesis, that capacity building program, to develop a level 1 trauma center in Rishikesh in my MCH, and under the guidance and support by AIIMS Delhi, JP and ATC, we developed a level 1 trauma center. State-of-art trauma center, but this center was opened on January 1st, 2019 at AIIMS Rishikesh. But within 6 months, we had a realization. There was multiple mass casualties. Bus fell into a gorge in Uttarkashi. 29 people died on the spot. 2 reached AIIMS Rishikesh. School bus fell in gorge in Tehri. 17 students, they died on the spot. 4 reached AIIMS Rishikesh. Bus fell into a gorge in Chilnali Sod. 23 people died on the spot. 6 reached AIIMS Rishikesh. And similar, many other multiple casualties. When we assess these casualties based upon their injury severity score, this is the score which we take out to see how severe a patient is injured, we realize that the patient reaching AIIMS Rishikesh were not very severe. They could have been very well taken care at a district hospital or a PHC, their plaster could have been done. So they were in no way in danger of mortal threat. So what is the relevance of a level 1 trauma center in a state? But we had one realization, next slide please, that patients are not reaching us within golden hour, the hour in which 80% of lives can be saved. This we understood. Next slide please. So we realize the mandate of AIIMS, which is in hospital care, is not going to work here. We have to focus on all the arms in the chain of survival. The pre-hospital care, that is taking care of the patient from site of injury till he reaches a specialized hospital. A state-of-art inter-hospital care, intra-hospital care, where there is everything, all the specialties available to treat this patient. Rehabilitation. We just don't have to treat these patients physically, but we have to make them economically viable members of the society. If a guard loses his limb, what will he do? He does not have an education. How is he going to? He'll be burdened on the society. So we have to rehabilitate them in a way that they become productive individuals of the society. And then, of course, while we are doing all these three, we also had to pitch in for policy and advocacy towards this direction, which I'm very happy that HIMSamwaad, we are trying to do it with their help. The last slide which I presented, I did that same in Solan, Himachal Pradesh in 2022. And I'm very happy to say that a lot of water has passed under the bridge, but we have something to show here. We could do something in between. So what could be done? The best thing is to see the best practices in the world, to analyze our situations and find out local solutions. We went to Israel, Rambam Trauma Center, amazing 750 beds they can make underground within 6 hours with all the specialties, dialysis, surgery, everything. We learned those systems from them. We went to Japan to study their emergency medical system. We realized that lives in our hilly terrain can be saved by decreasing the distance to the hospital. The aerial distance in hilly regions is very less, while the surface distance is huge. So somebody who gets a head injury in Kedarnath is not going to survive until and unless is operated in Rishikesh and Dehradun. And it takes certainly much more than 7 to 8 hours to reach there. So it's almost a death sentence. We studied the Dr. Heli model. We went to the first trauma center of the world, that is Maryland Shock Trauma Center. And this is the center from where the centralized emergency medical services, like Sir was saying, has evolved, and it gave the gift to the world about centralized emergency services. We studied their protocols. Now we are in academic collaborations with them. And then we went to Kernan to see their rehabilitation system, that how are they integrating people as productive members in the society. Next. We also studied models of third world countries which had lower economy than us, but better emergency trauma management. So we went to Thailand. They have an excellent models there under the leadership of people like Dr. Vitaya, Chabun Chachai and everything. And with their limited resources and their desi jugards, they're doing much better work than we are doing there here in India collectively. Next, please. Then we had developed relationship with all these institutes. Next. So what we realized was that the country needs to have a single access number for all these problems. People who are working in silos, transport departments are working separately, police is working separately, health is not talking to any other department. So when an accident happens, no wonder there are laws like Good Samaritan, because people are not helping anybody here. People are not talking. So people are working in separate environments. Those silos need to be broken. We don't have a cadre of first responders in the country. If you watch Hollywood movies, you will see that the people come, they treat the patients, the paramedics, they are well trained, they take the patients alive to the hospital. We have no such cadre in the country. What we have in our state is basically police and SDRF, that is State Disaster Relief Force, which was made in the state after 2013 incidents. We need to see what other stakeholders are there. We realize the taxi drivers in Uttarakhand are the first responders most of the times. During Char Dham or during whatever, they are the ones, the trekkers, the small taxis which work, they are the ones who reach the patient first before even anybody else reaches. And then we had to see what transfer methods were there in the state. Surface, we have 108 ambulances, but yes, there was an option which was not explored before we thought about it. Next. When I talk of universal number in the country, we have to realize that change begins at home. We realize that in AIIMS also we don't have one single universal number, a number in which somebody can call about his trauma and get everything, every possible help on this one number. So, October 2022, due to the World Trauma Day, we started our trauma telemedicine. This is a number at which anybody can call, not just, we are able to handle the load right now. And you can receive every information. For example, doctor, I got my hand cut in my hand, what should I do? Should I take tetanus or not? And if the finger gets severed, you can call on this number. Our team will tell you that how to wrap that finger in antibiotic and get it to the hospital in a water bath. If you are needed, responsibility of AIIMS Rishikesh, they'll reserve a bed for you, they will stop OT for this implantation. They'll stop elective surgery, they'll stop fractures, and they'll say this is coming, the implantation is coming. Because after 6 hours, the limbs cannot be implanted. So that is the number which we've taken care of, and I'm very happy to say that we have had we have helped more than 48,000 people through this telemedicine since October 2022. And 10% of them are life and limb saving things. So how many lives in morbidity this number has saved, I cannot impress enough. Next. So we got all the stakeholders under one roof. It is easy to do in smaller states. That is why if you're talking of HIMSamwaad, the governor comes here to inaugurate HIMSamwaad. We have direct collaboration. That is the beauty of the small states. You know, people listen to you. So we called up all the stakeholders under one roof. It was army, it was police, it was fire, it was administration, and it was AIIMS obviously. And we tried to get nodal officers from each the hospital. We tried to get mechanism. We tried to discuss how to collaborate, how to move forward. If such incidents happens, we made a WhatsApp platform after that, which we call the Uttarakhand Trauma Care Group, and all the stakeholders are in their group. If an accident happens, we post it in there, and everybody pitches in. And if somebody has not seen, we can call them up, and we know whom to call to in times of trauma and disasters. Next slide, please. We started doing this annual mega drill. So first time in 2019, we celebrate as a Department of Trauma Surgery and Critical Care World Trauma Day, which is on 17th October. The first year, we did a cyclothon. We distributed T-shirts, good photographs were taken, everything was there. It came into papers next day, but we realized that nothing concrete came out of it, just some good press. So we had to find ways that the celebration can become more meaningful. So we started World Trauma Week. In this week, we dispatch a trauma rath from the institute of our director dispatches it. It goes to the chief minister's house. He dispatches it from there. It goes to all the government medical colleges in the state where we hold workshops, basic trauma workshop and advanced vascular workshops, so that each one of them get involved. At least we get to know each other. The doctors, they can talk to each other. They have patients to refer to, and they have basic knowledge then whom to refer, when to refer. And then on the 7th day, we do an annual mega drill where we create an accident of 2 buses with 160 passengers, total 160 patients injured. And then we get all the doctors of the state who are dealing in trauma, we invite them to AIIMS Rishikesh and then show them that how these people can be managed in one single hospital with existing resources. So here we get SDRF also, because they are the people who do majority of time evacuations. So we are official trainers of SDRF as well. We tell them how to train, and we show all the doctors that how these patients are managed, how the codes are to be followed, how the code orange has to be followed. Next, please. And then we started training the first responders. This is the Uttarakhand police we started training. Then the COVID came, so we clubbed the program with COVID training and trauma training. Next, please. Then we trained the first responders from the taxi drivers. So we got fund for this. All other things are non-funded. I would like to bring in your information, sir, our chairperson, that all these activities are just purely on a voluntary basis. We don't take a single rupee for them. But this thing was funded by Road Transport Department. They sent their 50 taxi drivers to us, and we have covered 7 districts. 5 districts are still to go in Uttarakhand. So, and these are the main referrals today. They are the ones who call at our trauma helpline most frequently these days. And they tell us, sir, aapne kaha wala patient sick hai. It has to be shifted. We are shifting this patient. Amazing feedback from them. Next. Then we saw what were the pre-hospital stakeholders were there. There was SDRF. We went to SDRF. They were more than happy to appoint us as their trainers, and we train them regularly. Next. IDPP was also a force which we could involve, and they were more than happy to be a part of this wonderful cause. Next. Then we realized that maybe we should focus upon a very impressionable part of the society, that is the children, because these people have most of years ahead of them. So if you train somebody who's in 60s, it's better to train somebody who's early, so that thing remains with them. The problem is we have been training day in, day out a lot of people, but that does not translate into progress. So what we did was we identified 5,000 students from schools out in the side of Rishikesh. We enrolled them, and then we trained them every year continuously for 3 years. So somebody in 7th, they get trained, then they will get again training in the World Trauma Week when they're in 8th, and again when they're in 9th. So I'm very happy to say that when we go there second time or the third time, the seniors, the ones who are the third time, they'll say, "Arey sir, ye to hum aise kar dete the, ye aisa kar." They are the ones who are taking step forwards, and it's not complicated. To save life is not complicated if you know what to do in emergency situations. Next. So this is a teamwork. During this 1 week, some people go some place, some people go every other place, and 5,000 people, and sir, this is also totally non-funded, all supported by volunteers of Department of Trauma Surgery and Critical Care, nurses, doctors, and students. Next. 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 They're not just trained on trauma first aid. They are also trained on what equipment to have at their home and how to utilize those equipments to help the people in trauma care in their family. The goal is to have at least one trauma care provider in every family in Uttarakhand. Next. 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 We also do Nukkad Nataks. We evolve our nursing, which are very enthusiastic. They tell them in a very, very, very innocent and very creative way that what not to do. Next. Next. And then we were approached by the Civil Service Training Institute, and they wanted the trainee civil servants to be trained. We thought it was a very great idea. This recommendation came for people in our group when they realized that what they have discussed with us should go to everybody in the group. So now these trainees, they train with us for regularly so that we speak a common language in times of disaster. They know the medical terminologies, they know the urgencies. A few days ago, I got a call that this has to be evacuated from Uttarkashi. The DM told me that. And I said, he does not require. कह रहे डॉक्टर साहब ये सबसे सीरियस है, ये वेंटिलेटर पे है, इसको उठाना है, फ्रैक्चर वाले को मत उठाइए. I said, he is M1, उसकी सर्वाइवल का the possibility is the least. He will not survive. So we should take rather somebody who can survive. So this discussion eases off when they know whom to send and whom to transfer. And when the people who are the who take the call, who decide, who are the decision makers, know what to do, it becomes very easy for the society. Next. Next. So now, what about the transport? We talked about the manpower. So we realized that we had 108 ambulances in the state. And it had been doing very good. But somehow, what we realized that the clinical audit was never there. So, next, please. So these ambulances, though, now they have a very good network. They know where to go, what to do. But what happens is, they're never clinically audited. There's nobody to give them feedback. No. You don't have to take this patient here. If you could have taken this patient here, that patient would have survived. Don't take this patient to this hospital. There's no gynecologist. The patient will deliver, that baby will die. You have to, if this feedback is not given to these people, how will they know? How will they get better? And moreover, there's a thing that after 3 years when it comes, these are outsourced people, when the time of salary increment comes, they are shunted out. So now the new crop which comes are essentially drivers and conductors with no training. So we started talking with the state, and we have implemented some changes in the policy. Let's see how it goes. It was done this year only. Next. And then the realization that in Uttarakhand, heli services matter. In hilly states, heli services matter. It's not an expensive method of transportation, let me tell you that. As surgeons, we do at least 5 surgeries in our OT every day in which we utilize AIIMS. So we're using 1 lakh implant on knee, 1 lakh hip on implant, 75,000 or 80,000 rupees for a head injury patient we cannot afford. AIIMS can easily do that. So the thing was, we realized that it's a cheap way, because getting a hospital up in Kedarnath or somewhere in Uttarkashi with all the trauma paraphernalia is going to be very costly, and doctors are not going to go there. We are facing the dearth of doctors upstairs. So it makes sense to carry these patients, to get the health care. If you cannot get the health care to the patient, we get patient to the health care. Next. So we started this first air ambulance service. We designed the helipad, took relevant permissions. Next. And then after trials, we were given to run the first emergency services of the country. Next. So this heli services, the mandate is life and limb threatening injuries. Any injuries which you suspect is life or limb threatening will be taken care by this service. The last one is Chinook. I'm very proud to say that we are the ones who were medically created SOPs for those 40 patients in Silkyara tunnel. They evacuated to AIIMS Rishikesh. Next. So this picture is very close to my heart. The first picture, if you see, there I am with my son. He was very small then. And the foundation of this helipad was being made. So I took him. I said, come here. He said, what is it? I said, you won't realize it now, but in future, one day, when you see back, then you'll realize. And I made him put his feet there, though it was covered by concrete, but he always says, I have, after it's a success now, he tells his friends, mera pair ka footprint wahan pe hai. Next. So AIIMS was then cleared for regular air operations. Next. Next, and we had many success stories because of these heli services. Next. 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 We are in a process of developing a course because we are first in the country. So by the end of this year, there will be a course for anybody in the country to come and study with us and get a 1-year fellowship for aeromedical services. The course is for only medical professionals. Next. This is our data. So till now we have evacuated 308 patients, of which most of them are trauma and then other problems as well. Next. And no doubt, anybody from Uttarakhand, they know that acceptability in the state is very much for heli ambulances. Next. So in hospital trauma care, this is basically my core competence, but this is not a platform to discuss this, but to tell you frankly, we did everything in AIIMS Rishikesh to develop in hospital care, and there's no patient we have referred till date for the lack of services in AIIMS Rishikesh, be it cardiac trauma, be it implantations, be it whatever. Next. So now, came about rehabilitation part. This is a part where we're still working, we are still lacking. Next. So we've started an amputation clinic at AIIMS Rishikesh. On Tuesdays, we have an amputation clinics. We have partnered with AIIMCO, that is Pradhan Mantri Artificial Limb Yojana, in which patients who have less than 30,000 salaries per month, it's not a very poor patient, can get limbs for free in AIIMS Rishikesh. And these limbs are not Jaipur foot, these are much better. You can run with these limbs. So we started that. We have a PMR department, so that is strength in the physical rehab. One thing we require is social rehab. So if anybody wants to partner us for social rehabilitation of these patients, we are open for partnerships here. Next. So this is a glimpse of our robotic training or gait training centers. And then I want to talk about success stories. Next. So this was a person with his hand severed at shoulder at a construction site. This is in Pithoragarh. Rishikesh is in Garhwal. There's a huge distance between both the places. And can you please click on the video? This is the first shoulder implantation in our state that was done at AIIMS for this patient. I got a call from district magistrate there. She was a lady. She said, Doctor, I told her that if you want us to implant the limb, please send the limb within 6 hours and the patient within 6 hours. Because if you are unable to do that, we won't be doing that. So, limb was sent. Patient was sent before, but then they realized the limb is back. The limb was sent in a polythene after some time. But we could manage him. The patient has a functional limb now. Next. Next. So these are all patients which I want to tell you because this is a rod. Patient's car went into gorge and there were rods jutting out. Inside the car, it went all through his chest. Brought in time to Rishikesh and then we saved him. And he was not brought by a heli ambulance, he was brought by surface. But the best part was the places, the Halwani Medical College where we go to train every week, they knew that this could be done at AIIMS. So without delaying, they called us, they had my number, they realized that we are interested. मैं भेज रहा हूँ, immediately भेजिए sir, we'll take care of this patient. Went home after a week. Next. And this is the first heart surgery in AIIMS Rishikesh for trauma. Stab injury to the chest, patient came from Roorkee, went home walking after 1 year. Can you just click on the video? The left. So this is a patient with a stab injury. We did not have time to take such patients to OT, but because of the protocols, you can see that we are not wearing aprons, only one person who came later. This was done in emergency department, outside in emergency on a stretcher, because patient did not have time, but we had protocols in this place. We had anticipated things like this. So it was done in our emergency and the patient went home surviving. And if you just click to the end of the video, you'll see that the flabby heart, which is flabby right now, starts beating again and the life is saved. Next. So now the last part of our strategy was policy and advocacy. So how to deal with policy and advocacy? So we started that it cannot happen in silos. If AIIMS thinks that our mandate is in hospital care and we'll just do that and people will come to us, we'll not be able to have a sarthak life. So we started coordination with the state government. We advise them on Char Dham. We make protocols for them. We train the first responders of the state. We train the doctors of the state for Char Dham Yatra. And right now we are training doctors of AIIMS for Char Dham Yatra who are joining the Char Dham Yatra as medical. They stay with us in Rishikesh for 2 days and we give them a brief of the training. We were the master institute for Vaibhav Summit in trauma delivery in hilly regions. That was started by Honorable Prime Minister. And now we are focusing upon EMTALA, that is Emergency Trauma and Labor Act. We don't have to reinvent the wheel. The West has done it before. We have examples in front of us. So now our focus is on that. So we are collaborating with all the institute and all the stakeholders of trauma to make certain that a very good law like EMTALA comes in the country. Next. So this covers almost all the 4 arms, and this, my friends, is journey of only 5 years. And most of it is journey where we crystallized the problem in last HIMSamwaad Yatra, in last HIMSamwaad in Solan. That time we had identified the challenges, we had crystallized the challenges. Now we did something on our own. We did not look for resources, we did not wait for resources. And whatever we could do, and I'm proud of whatever we've done. We could have done much more with help, but at least this is not less. Next. This is Vaibhav Summit. Next. This is a collaboration. And now the best part, next slide. So we are the state, resource health, SRHC has come now. So now they have taken, we are very happy that they have taken trauma, development of inclusive trauma center, which incorporates all the 4 arms as the first project there. I'm very happy that we have been making a progress. It has been just a few months only. Next. So what we have realized is public-centric approach is required. If you think about AIIMS, if you think about state government versus central government, you think about our duties versus any other duties, things won't happen. We have to think about the patient. So when we think about the patient, we all become friends. When we think about the institute, we become enemies. A personalized approach is required. What we realized was when we are dealing with these things, so we have to know the name of the first responder who's working at the field. The taxi driver, we have to acknowledge him. Arey Suresh, tune bhej diya yaar, tera pichla patient theek tha. Imagine if we are a dalda maker, we make dalda in say Rudki and we have to supply it in Uttarakhand. We'll know the name of all the distributors. But when it comes to policy, we check. Wahan bhej diya, wahan bhej diya, wahan bhej diya. So personalized approach is required. A little effort to know your team, know the people you're working with, that is required. And the last thing is everything is possible. That from the past 5 years of experience, there's no scope for nihilism. Things happen. Next. Thank you very much.